Well, welcome, ladies and gentlemen, to this July board of SWFT Foundation Trust. Lovely to see so many members of the public joining us, and lovely to have Carolyn Bell standing in for Bhaskar this afternoon, and Jack standing in for Harkamel. So without further ado, I don't think we've got any other apologies, have we, Sarah?
No, Russell.
Okay, we've had a busy morning already for members of the public and a confidential board after this meeting. This morning we've been discussing how we can further improve our governance arrangements, addressing any areas that following a further review that we might even further improve on. As ever, life is a continuous journey. We found a few areas that we want to improve on, and so we will be doing that. Any new declarations of interest on today's agenda, team? Could you please raise a digital hand for me? Okay, so the last set of minutes held on the 4th of June. If there are any points of accuracy on those, could you raise a digital hand for me, please? Okay, can't see a digital hand raised. So we will go therefore on to matters arising, which is on page 16 of our pack. The first was for Harkamel and I to visit the security team at SWFT. We did that. I'd just like to put on record my enormous thanks to Fiona and Mark and all of the other team involved in that. Whilst it's a contract that we have with the security team, the work they do in terms of taking out the stressful situations that occasionally arise in A&D elsewhere really is quite remarkable. So I do want to thank all of our security team at SWFT and on our other sites for the work that they do. No one comes to work to be abused or physically intimidated. So I would just say to members of the public, if you are coming to the A&D, you don't have the right to abuse anyone, and you certainly don't have the right to physically intimidate any members of staff. But thanks to our security team for the protection they provide when necessary. The next was on the Trust Strategy Review, which is coming back in September. So thank you for that, Sophie and colleagues. Then we had the Freedom to Speak Up Guardian to provide some benchmarking data across the foundation group. That's coming back in September as well. Then Harkamel to provide oncology as a particular focal point. You'll cover that off, Jack, in a little while. I would just like to say though to members of the public, it is a continuing area of concern for us, our cancer performance. I think members of the public may be aware that the oncologist part of our cancer service is provided through a service level agreement with UHCW. And that's in particular the area where we're having some challenges in terms of turnaround time. But I know the team are doing a lot of work on that. And then ELVA to provide some alternative options for occupational health service. ELVA, I understand the business case is coming forward to us shortly. This is a service again which is provided by UHCW, but for all of our NHS employees throughout Warwickshire and Coventry, we need a better solution than we've had over the last couple of years. ELVA, is there anything you'd like to add to that?
Just to say that we have just finalising the options appraisal, which will be done by this week. So we will be in a position to hopefully bring that to the next board. Okay, that would be great, Elva, because we need to sort things out as quickly as possible. And then Fiona to ensure the outcomes of the specialist palliative care service or review be included in the September board pack. How's that coming along, Fiona?
Yeah, so we are expecting it to come to clinical governance. I am assured that the governance around end of life has improved, the leadership has improved. They are making a good improvements, particularly on some of the areas of risk that we have talked about here before, which is around availability of drugs in the community, for instance, access to palliative care, specialist nursing. So I think there's progress being made. It's not there's still some risk, but we'll hear about the more detail of that when it comes through clinical governance and board next time.
Okay, that's great, Fiona, because as we often say as a board, we have three sort of priorities in my view. The first is to bring life safely into the world. The second is to allow life to leave the world with dignity. And the third, when people have got in a medical emergency, to be able to access our emergency department as quickly as possible. So that's really important. So thank you. Any matters arising the colleagues feel we've missed? Okay, just as it's on the agenda, this is a really quite important week for the NHS. A whole series of things being announced. The first is the 10-year plan, which will be out at the end of this week. So we look forward to that. I think there will be a real focus on the three big shifts, which the Secretary of State have talked about before, of an increase in prevention, an increase in digitalisation, and an increase in home healthcare being delivered in the home. So they're things we are working on, have been working on for quite a while, but that will be out at the end of this week. There has been the decision to cluster the Coventry and Warwickshire and Hereford and Worcester ICBs. That decision has been signed off and will start to be implemented in coming weeks with the appointment of a chair for that expanded ICB. And the third thing that I expect to be announced this week is a new national operating framework, which will put all trusts into one of four segments. I'm pretty confident that we will be in segment 2. The only thing that stopped us getting into segment 1 has been some of the issues around cancer and 62-day waits, which we hope to address with colleagues in the system as quickly as possible. So without further ado, one of the things I think we can be really proud of as a trust is the work we do on sustainability. So Sophie, do you want to just outline the green plan for us, please? A big document, but if you can summarise it, that would be wonderful.
Yeah, thank you. So really delighted to be here presenting our next 3-year plan for the trust. Chris Kaleja, our sustainability manager, has led this work, but it's fair to say that there have been multiple people across the organisation involved in its contributing to the development of it. So we're really fortunate to have leads in each of these spaces that have been heavily involved in setting the targets and setting out what we think we can achieve in the next 3 years. There's a renewed focus on clinical leadership into this area, and it's great that we've got Carolyn Bell as the lead for us now in the trust, and we'll work on getting the divisions to also identify leads for this area to help contribute to the delivery of the plan. And that's the big ask for NHS England over the next 3 years. That's the one thing that's sort of changed in terms of its focus. In terms of the assurance here, this does come to the board on a regular basis. We also have a sustainability strategy group that review this. We do deep dives on each of the areas, and where the areas are not delivering against the targets, we kind of wrap some extra support around them, and we really understand how we might be able to move that on. The other thing to note is we did this in partnership with George Eliot. We have shared functions already around procurement, so actually together we can be much stronger on the delivery in some of these areas. So here really for approval of the board today.
That's super. Thank you, Sophie. And I know some colleagues sometimes wonder why we have such a focus on sustainability and our green plan. If you just want to experience the weather that we have over the last week or so, and the weather that is being experienced in Europe at the moment, there's absolutely no doubt our weather is changing, and therefore, as good corporate citizens, our work in this area is absolutely essential. Any questions or perspectives? Adam?
Exactly as you've said, Russell, it is important in terms of the climate. We also know that the NHS is one of the biggest carbon producers in the country. I think on top of that, when we hear our staff talk, they tell us how important this is to them. They're really passionate about our response to climate change. So I think it's absolutely right we respond to our staff like that. I just want to say thank you to Sophie. I think this is an excellent document, and to Chris Clare and Sophie's team, who's put a huge amount of work into this. So thank you and well done. Sophie, you mentioned in particular the partnership with George Eliot on this. But beyond that, I think partnerships are quite important in our green plan. Is there any more you could say to us about how we're working with other system partners to drive this forward?
So there's probably two examples I'd give. One is the Green Champions that SWFT ran and initiated, that then actually through Chris's persuasion skills, we managed to get the Integrated Care Board to then lead it the second year. We got all partners involved in that. So we really did some of that sharing of best practice. So wherever we get that opportunity, we do that. The other thing is having a shared climate adaptation plan across the whole Integrated Care Board. I think it's fair to say that we still need to do some work on making that specific to each organisation, but it at least means all partners are moving in the same direction. And again, there's that sharing of best practice and that economies of scale. So I actually think the partnership's working quite well. The partner that does a lot in this space is our district councils. And then that's probably through our place working that we look to work with the district councils around what more we can do as kind of a place partner in Warwickshire, North Rugby and South.
Okay, great, thank you. Any other questions to Sophie? Sophie, I'd just like to endorse Adam's sort of appreciation for your leadership in this area. And we're really close in terms of opening up our new reception area and elective hub. Can you tell us when that's going to be open?
End of July.
Exciting.
The commercial partners want us to wait.
Okay, so if you're not happy to approve our green plan, could you raise a digital hand for me, please? Can't see any digital hands raised, so we will move on then to the Acting Chief Executive's report. And Adam, over to you.
Thank you very much, Russell. So Russell mentioned earlier the publication of the 10-year plan later this week, we believe. Really important document, will help shape our direction as an NHS and as an organisation for the future. One thing I would say, though, is from what we know of the 10-year plan, it's already very well aligned to our big moves, the shift to prevention, the shift to out of hospital, the shift to digital and so on. So I think we're in a good position to capitalise on that 10-year plan. One of the things that has come ahead of the 10-year plan is the urgent and emergency care plan, particularly focused on this winter. I think there is recognition that for the NHS, this winter is going to be extremely challenging. It's also going to be seen as this government's first winter, the first winter where its feet are really under the table. So I think there'll be a lot of focus on how the NHS responds. The plan focuses on two specific areas for us. One is about working as a system to support winter, and in particular looking at how we intervene really before people get into hospital, and indeed respond to get people out of hospital as quickly as possible, recognising particularly the impact of some of those seasonal illnesses we see people get when they're in hospital. The other is developing and testing the plans earlier. And as an organisation, we've been working with our system partners over the last 3 months, really, to review last year's plans and put plans for this year in place. We had a really positive care collaborative session with partners across Coventry and Warwickshire a few weeks ago, where we reviewed in detail some of those aspects of those winter plans, and in particular talked about some of the partnership initiatives. One of the big ones for us being our community recovery service, which is of course a partnership with Warwickshire County Council Social Care to help discharge patients from hospital more quickly with the appropriate support needs. I think there's also going to be some really targeted initiatives as part of the plan. So we can't undervalue the importance of prevention in our winter plans, and a really big aspect of that is the vaccination plans. So we will be working with our staff to make sure as many as possible are vaccinated. But within Coventry and Warwickshire, there will also be some targeted initiatives for communities in particular where vaccine uptake has been low in the past. I would encourage all members of the public listening to get a vaccine if they're eligible to a flu vaccine or a COVID vaccine, because you do not want to be unwell and ill and in hospitals over winter. I think it's a really important message that we'll be reinforcing as a trust. Moving on with some of the other elements of the report, we are in a period where some of the capital developments, major estate schemes that we've been talking about for a number of years are really coming to fruition. A couple of those that have opened in the last month are the new Community Diagnostics Centre, which is an extension of the existing new Stratford Hospital building. Fantastic facility that consolidates and enhances our diagnostics offering to residents in South Warwickshire, and well done to the teams who've got that up and running. The other huge development is the Ellen Badger Hospital, which opened last month. And the Ellen Badger Hospital is providing enhanced outpatient facilities for consultant-led outpatient services. It's providing a health and wellbeing hub, and I'm pleased to say we are now in really advanced talks with primary care to co-locate some of their facilities in the building. So it'll be a fantastic new facility for those services for patients. It will also be a hub for our community teams in Shipston to be closer to the populations they serve. So really fantastic stuff there. We're also having a conversation about other services we can develop and co-locate there, which again I think will enhance the offering for patients around the Shipston area. I know members of the community have been in the building and having a look around, and we've had some good feedback from that, but a great new facility there. Fantastic. The final development, which is just about to come to fruition, Sophie and Russell have already stolen my thunder on, and that's the big new building in the middle of the Warwick Hospital site, the first stage of our elective hub development. So the ground floor of that will be hospitality facilities, a new canteen and shop, and opening in a few months' time a new outpatient pharmacy facility. Within the next year, we will open the first and second floor, which will replace some of our really outdated day case wards. So great news that those developments are coming to fruition, or have now opened. I also want to mention another estates development, the opening of the Willow Room, which is a bereavement room in our early pregnancy assessment unit. This was developed based on feedback from patients of the trust who said that the environments where we were breaking bad news weren't ideal. And while our staff are compassionate and supportive, we needed a better environment to do that. We've been really lucky to be able to work with the Teddy Rose Foundation and the Lily May Foundation to support the development of that new room, which opened last month. So thanks to them, and thanks to the teams that have supported that. Also want to congratulate Russell. I won't say too much to spare his blushes, but obviously Russell was awarded an MBE in the last month, so congratulations to the chairman. And while we're on congratulations, it missed the deadline for this report, so it's not in here. But last Thursday, we won an award at the HSJ Awards. We were actually nominated in 3 categories: one for our real-time ward management system, one for our wound care system that's been piloted in out-of-hospital services, a new digital tool, and one for the Lola chatbot, which is an AI tool that's supporting our wheelchair services. We won for the Lola chatbot, and we were highly commended for wound care, but it's fantastic to be nominated and shortlisted at all. So well done to all 3 of those schemes that were represented in the awards. Finally, the report has the More From Our Great Teams section, which covers Rugby Place, the Rugby Place community teams this time. I think it's really important to acknowledge here that while we're called South Warwickshire University Foundation Trust, we do cover services across Warwickshire, community services across Warwickshire. So the focus this month is the services we've got in Rugby. Fantastic services there that are really supporting some of the urgent care services in Rugby. We have the falls pickup service there, for example, which is detailed in the report, which is supporting people not being conveyed to hospital when they've had a fall. We also have the urgent care response team, which has consistently exceeded performance targets and does a really fantastic job. The wound care app I mentioned previously was also piloted with the rugby teams, and generally in rugby we have some fantastic services, so I'd like just to thank them and recognise their great work here. That's all I've got in the report today, but happy to take any questions.
Thank you, Adam. A particular shout out for Sami Al-Daif, our consultant, who was so involved in the fundraising for the Willow Room. Sami, I think, is coming up for retirement soon. So, Sami, on behalf of all of the board, and Caroline, if you can mention it to him, thank you very much for your years of dedicated service. You've touched the lives of many families in the work you've done, and you should enjoy your retirement with pride. Questions and perspectives to Adam? What are you most worried about at the moment, Adam?
Challenging demand. We're still seeing really challenging demand numbers through our front door. I was going to mention in the IPR, but I'll mention now. I'm obviously really worried about oncology services, and we'll have another conversation about that in the next item. It's also a really tight year financially, and while our teams are on their planning and delivering their financial plans and savings, it is a really tough year. So those are probably my three top worries at the moment.
Great. I mean, it's worth just reminding members of the public that demand into our ED over the last 5 years has increased by about 35%. We're seeing day in, day out about 35% more people than we were in 2019. To put that into some context, UHCW are seeing 4% less. So it just goes to show how busy our ED department is, and thanks goes to them, Rachel and everyone down there, for the work that they do. Shall we move on then to the integrated performance report? And Adam, if you could perhaps introduce that, then we'll get into the detail with colleagues.
Sure, I'll be very brief in my introduction. I think a mixed picture in the last month. On the one hand, we saw waiting list decreases and more patients being treated within 18 weeks. On the other, we saw the impact of some of that demand at our ED, at our front door, which impacted on performance. We're also doing some really focused work on making sure we've got a broad spectrum of patient feedback. We always welcome feedback from our patients, and we obviously offer surveys. We offer the opportunity for people to feedback, but we are looking to do more of that to make sure we've got that broad picture. I think the other thing I've mentioned already, the financial challenges. We were off track in month 2, which is reported here. We have good plans to get us back on track. We'll start seeing some of our savings schemes delivering over the coming months. So we do still predict getting back on plan. I'll hand over to my colleagues for the detail.
Okay, great. Thank you, Adam. So I think we'll do quality and safety first. And Caroline and Fiona, over to you.
Yeah, thanks, Chair. So in summary, from a quality and safety point of view, I can provide assurance to board that our services are safe. The majority of the KPIs are within normal limits. I just want to pull a couple of points out though. So you'll see from my report that the incident reporting has been going up recently, and we've done a deep dive into that, and we believe that the causation of that is our change over from Datex to in-phase, and the category drop down lends itself to putting low harm rather than no harm. There isn't a category that is a near miss any longer, that which there was on in phase. So they're tending to put a degree of harm. All incidents are scrutinised by the patient safety team every morning, and a report comes to me as well. And obviously we change that rating of harm level if need be after investigation. So I'm not concerned that is actual harm to patients. It is the system that we're using now. Harms have gone up, falls with harm have gone up slightly this month, but again, not statistically significant and within the expected level. The area that I am concerned about is our patient experience data. Just to assure the public and the board, I'm not concerned about the actual experience patients are receiving. FFT recommendation, it remains strong, and with majority of our patients recommending our services to their fans and friends and family when undertaking the FFT survey. However, we have seen an increase in formal complaints, and we're still struggling to respond to complaints in the expected time frame. Part of this is to do with gaps in our patient experience team, and I am concerned about the fragility of that team. There are 2 people on long-term sick, and it's only a team of 5. So we have asked for mutual aid from George Eliot, and we're just exploring that and looking at how the team is structured to enable them to continue to manage that. But I will continue to provide an update to board and through patient experience committee and through clinical governance committee on that one while there is concern. The last section on my report is around the VTE risk assessment. I'd like to assure board that we continue the triangulation that we've always done on VTE, which is if we haven't done the risk assessment, are the medical teams still prescribing prophylactic VTE, and are patients actually getting a clot whilst they're in our care? And both the answers to both of those second questions are positive. They are prescribing prophylaxis when needed to, and we are not getting an increase in incidents around embolism. The documentation of our risk assessment is an improving picture. We are doing a lot of work to enable medical teams to understand their responsibility, to access our systems in the easiest possible way, and to document that risk assessment. And as you can see from the dashboard, it is an improving picture. We are auditing that on a monthly basis now.
Thank you, Fiona.
Thank you.
And Carolyn, anything you'd like to add?
I echo sort of Fiona's comments that really we are assured that we're providing a good, safe standard of care for our patients. And there's a really positive news story from our mortality data that we see a continued and sustained reduction in both the HS, the shimmy and our RAMIs. There are a few areas where the RAMIs are a little higher than we'd like, and in those areas we've undertaken deep dives, we've learned from them. We're already starting to see a reduction in the RAMIs in 2 of those 3 areas. We continue to have control and a grip of that through the Mortality Surveillance Committee. So those are the main findings, but really positive overall from that perspective.
Thank you, Carolyn. Questions and perspectives then to Fiona and Carolyn on quality and safety. David, as chair of our Quality Assurance Committee, how are you feeling about things?
Sorry, I'm trying to find my mic. I'm quite comfortable about how things are going. I think I'd echo Fiona's points about the improvement in actually the improved incident reporting and the assessment of whether it's something we should be really concerned about. I'd agree with her that after further work, it's quite clear that there are system issues that are causing some of that rather than actual harm to patients. So overall, I'm pretty comfortable with the situation.
Thank you very much, David. Colleagues, happy to move on then to the operational performance. So, Jack, thank you for standing in for Harkamel today. What would you care to pull out of Harkamel's report?
Thanks, Russell. As yourself and Adam have alluded to, very busy on an emergency basis again in May. Saw a further increase on April as the month before, 803 more attendances. And we also saw more patients than we'd seen last May as well. So on a continued trajectory there in terms of that increased emergency attendances. As a result, there was a slight decline in our 4-hour performance to 70.4%. We have handover delays worsened slightly in May as well. There were 127 handovers were delayed, so that was up 22 from April. In terms of stranded numbers, they do remain very high, but there were some early signs of improvement at the 7-day mark. We saw our average length of stay continue to improve, and that fell to 7.2 days. Moving on from some of those emergency headlines, diagnostic performance improved in May, reached 95%, and at the end of the month, the waiting list had declined further to 8,040 patients, which is the lowest it's been for some time. So it's great to see that improvement trajectory. And RTT performance also improved up to 65.7%. Again, further reduction in the waiting list down to 31,909, so down 500 from April, and we continue to be better than 75% of acute combined trust nationally. So really positive there. The long waiters that we do have remain concentrated in orthodontics and oral surgery, but the position on that is improving. In terms of cancer, 62-day performance, again, we saw another improvement here at 68.8%, but unfortunately, we're unlikely to continue that improvement through May with the patients that we know are coming through, although we are expecting to be above the February and March performance. We've mentioned the challenges that we've got around oncology, and as you said, the oncology services are provided by UHCW, and the delays remain a concern for us. There have been some improvements in gynae oncology, where at the moment there is no delay to first appointment with an oncologist, and both gynae and breast patients being offered their appointments at Warwick and Coventry to try and help reduce that waiting time. Unfortunately, we're not seeing any improvement in urology, with 19 patients who have no first appointment to book, and the average wait is now about 20 weeks, which is a very concern. So we're continuing in conversation with UHCW, and they're going to be putting on an additional weekly clinic for urology. However, some long-term absence remains a challenge there, and we are exploring other mutual aid options as well to kind of meet that challenge. Moving on from that then, urgent community response remains very strong, with 90% response rate, just under that. And maternity services saw a shift in delivery modes, from vaginal births decreased to 45.7%, but a rise in emergency caesareans to 27.2%. I won't go into detail, and I'll take it as read, but there's a bit of a deep dive into our stranded patient review process, and what that looks like, and the outcomes and some of the improvement trajectory we've seen through that work. But I'll take that read. I have to take any questions on that or any of the update. Thank you.
That's great. Thank you, Jack. Questions and perspectives to Jack and operational performance, Robert?
Well, Jack, I was just going to ask, I appreciate your reporting on the month of May, but with this sort of stretch of extremely hot weather that we've had, have you seen any kind of discernible rise in admissions or walk-in activity?
We have noticed over this week an increase in walk-in activity. Yes, especially again from out of area. Unfortunately, we continue to receive IC in, and have done at the beginning of the last 2 weeks, where we've had very busy beginnings to the weeks. We're in conversation with almost when that happens, but in terms of the walk-ins, I was on call yesterday actually, and we were seeing a significant increase in walk-in attendances from out of area, which is very concerning, and we'll keep a track of that activity. I think we referenced it this morning, and probably regularly around the activity that we seem to be receiving from Coventry Rugby and out of area, and recording, whether that's via ambulance, via walk-ins, and addressing that with system partners.
And any other questions or perspectives, Paramjit?
I think Oliver was before me, Chair. If you want
Well,
to go.
as I've called you out, Paramjit, you
Okay,
go first.
thank you for that.
Oliver.
Just for clarification, Jack, if you do know, it's 14 patients didn't receive their oncology treatment within 31 days, but 4 of those chose not to delay this. Now, do we still include those 4 in our denominator in terms of target? Because people can choose, obviously, when they want their treatment, but in terms of our target, should they be included? Maybe one of our other executive colleagues can answer that.
Jack,
I believe they are included in the target still in the denominator.
Okay, thank you. Need to maybe think about that, Jack. I assume that's a national requirement, but and Adam's nodding. Oliver?
Thank you. Well, firstly, well done, because it's been some really challenging times with the volumes increasing and you're still keeping on top of it. So thank you for that. In terms of the 4-hour wait, though, so I mean, it's great that you're at 70%. You went down 2%, but the attendance went up 10%. But what's your confidence with the attendances continuing to rise that we'll be able to achieve or get back to the national standard?
National standard in terms of what, Oliver? The RTT?
The 4-hour wait.
Okay. Adam, did you want to come in on that?
Shall I take that one? It's a bit unfair to put Jack on the spot with that one. So I think it is a challenging picture, and we are certainly still seeing those demand increases, particularly from out of area, as Jack said. That said, we have a really good team in our ED. Certainly in June, certainly in the first half of June, we were above our trajectory for improvement. I think in the last couple of weeks of June, as we saw the effects of heat and as Jack said, the increase in some of the walk-ins in relation to that, we did see a slight deterioration, but we are still there or thereabouts at our trajectory. I do think it's an area we've got to keep watching very closely. We just cannot keep meeting a sustained demand increase of the size that we have. And we have and continue to escalate that to system partners and NHSE. The area where we are seeing the most significant growth is walk-in activity from Coventry and Rugby. And I am really keen to work with the ICB. In fact, we raised it in our provider review meeting with the ICB last week for some public awareness campaigns about the fact that the nearest A&E to those residents is not Warwick, and they may want to consider their options.
Yeah, I think just building on Oliver's point, it would be, I think, worthy of a workshop, Adam. 2 things. If we take the sort of government focus, which is going to be on 4-hour waits and 18-week RTT at 92%, it would be good to understand what we need to do as a trust to achieve those targets by the end of this Parliament, which is the government's intent. And I think on the 18 weeks RTT, that's more within our control. As we've sort of just been discussing on the 4 hours, we need, to be honest, system partners to share the love a bit more. It self-evidently is not fair to our team that there's a 35% increase in volume coming into us when there's a 4% decline at UHCW. We need to rebalance that demand more fairly, and our ambulance colleagues have a part to play in that as well. And Barty?
Sorry, Russell.
Oh, sorry.
No, because I completely agree with that. That's a really good idea. And I just wonder in that workshop whether it would be too much to ask system partners to at least be part of that, to ensure that because we see a common trend here, don't we, without those volumes changing, with the oncology point that you made, so potentially bringing them to feel that they need to be part of the solution in that might be helpful as well.
Yeah, no, my concern, Oliver, is by us taking more and more of this volume, we're affecting our performance and helping their performance, and that's just not fair. Barty?
Yeah, my point was again around the growth that we're seeing, but more in relation to oncology services in respect of meeting the targets and ensuring equity of access to our citizens for diagnostic and time for treatment. And I just wondered whether the SLAs we have in place with the support we received from UHCW, whether they're reflective of our future needs, given the level of growth and demand that we have and the targets that are set on us, and whether there was an opportunity to sit down at a system level to have a look at, you know, disproportionate growth levels, or what the requirements are in terms of our patients now, to make sure that we have an SLA that's reflective. Because if there are capacity constraints across the system, we still have to find a solution to make sure patients get timely diagnostics and treatment. Thank you.
Yeah, Adam, shall I go first, just because it's maybe a little bit easier, and then you can be more delicate. I think that there's clearly a national challenge in terms of oncology, oncologist supply. So everyone is suffering from this. I think the concern at the moment is there is a danger of differential access dependent on location. And we do have some evidence that if you're living in Coventry, you're seen by an oncologist faster than you're seeing if you're living in South Warwickshire, and that can't be appropriate. For members of the public, when we talk about SLAs, that's service level agreements. So it's where we pay another part of the NHS to do something for us to a certain standard, and that isn't working. You're quite right, Barty, as well as it should. So I think a big system challenge. I think the coming together of Coventry and Warwickshire and Hereford and Worcester should give us more leverage. So this is going to be very much a live debate over coming months, as we really do need to deliver for the citizens that we serve. Adam, is there anything you'd like to add to that?
Yeah, I think we need to move away from SLAs in the traditional sense to a more demand-led model of using resources from partners. And we have had some conversations about, I think we're way off of it, but we have had some conversations. Some of this work, we're part of an acute provider collaborative, and some of this work is being led through our provider collaborative and the clinical networks that report to that. But I do think we need a model that's much more flexible. We've seen really challenging demand changes, and we see demand changes month on month as well. So I think that reflexive model is important, but also the ability to look at mutual aid arrangements outside of the system or outside of the traditional system, where there is a demand need to do so, when we can't meet the numbers in system. And all of those conversations are being had.
Yeah, I think we need to, and this isn't a comment about us, it's about the system in its general terms. We need to speed up our decision making. You know, we're good at talking about this stuff. We're not always good at implementing change at pace. And I would very strongly counsel that what we're doing at the moment and the way things are being done isn't working. So let's change things to what we think will be some improvement on a better done than perfect sort of mantra. Good discussion, team. Jack, well done for standing in. And so we'll move on then to our workforce and our Acting Chief People Officer. Elva, lovely to see you.
Thank you. Yeah, so our position is quite a good one in terms of our KPIs. We have seen a further reduction in our sickness absence across the trust. We're now down to 4.98% against the target of 4%. Similar for our turnover, there has been a decrease within quite a significant one to 7.67% from 9.53%. And with our appraisals, we've seen quite a significant increase, which is very good. We are still quite short of target at 79% against an 85% target, but certainly a move in the right direction from previous month. Our stat and run training is also looking good, so we're definitely going in the right direction. There are still areas within sickness, particularly within some of the divisions that are still very high and our particular hotspot areas which are receiving targeted support. Happy to take any questions.
Thank you very much, Elva. Questions or perspectives to Elva? We were talking about, sorry, Robert?
Well, I was just gonna, that's, good news on the sickness level. What's your confidence level on that kind of starting a sustained trend?
Yeah, I think considering where we came from in terms of our sickness absence, it was nearly 7%. I think our confidence in keeping it down, we need to look at that and see, hopefully we can sustain it. But with the additional support we're putting in, I think it's definitely something which we can sustain in terms of kind of longer term, but our peaks are very much during the winter months. So we need to keep a particular eye on it during that time, and out of hospital is a particular area division that we support significantly in terms of sickness absence, because they have the highest across the trust.
And it's interesting, Elva, that I think 32% of sickness absence is from stress and anxiety and depression. We used that SLA a moment ago, and our occupational health work that we were referring to earlier is dependent on an SLA with UHCW again. So we really do need to sort that out. So we're being a good employer and helping staff with the moral injury, which a lot of them do have to cope with in areas like ED when the demand is as relentless as it is. Read the statutory mandatory training and appraisal side. What are we doing here so that we can reduce the risk of failing on that?
So our statutory and mandatory training has increased significantly. So we're doing well there. Our appraisals has dipped below what it was, and it over the last year has been below target. So we are picking those up through our finance and performance executive meetings, looking at each of the divisions in detail as to where they are with regard to their appraisal rates, and asking for a trajectory action plans against those to ensure that they're able to get up to target. But also we have just implemented a new system for recording of appraisals, which is the same system we use for our statutory mandatory training, and that will also hopefully help in terms of logging appraisals, undertaking appraisals, making the paperwork and the logging a lot easier than it has been previously when we've been relying on managers to use ESR.
Okay, so CQC flagged this, as you indicated in the report. When will we be in a position where our performance is at the level it needs to be?
So for appraisals, we're giving it a really good push in terms of getting up to target. So I'm hopeful that we can get there within the next month. Looking at the trajectory over the past couple of months, we have seen quite a significant percentage increase month on month. So hoping we can get there for next month.
Okay, good. That's what I like to hear, Elva. Thank you. Shall we move on to the money? So Kim, it's been a tough couple of months, and we need to turn the trend to make sure that in terms of the national operating framework, we don't end up in a problem after the first quarter. But Kim, how are you seeing the money at the moment?
Yeah, no, thank you, Russell. So as Adam pointed out earlier, we did set a deficit plan for month 2, and we are away from that. So we're reporting a £3.9 million deficit versus a £1.8 million deficit plan. So the main driver really is around the operational pressures and the escalation capacity that we've had to open in order to meet demand, as Jack has made reference to. The other key things that we need to ensure that we deliver on, though, to meet the rest of the financial plan for the year, is to ensure that we deliver on our cost improvement programme. And pleased to say that the divisions have identified the full amount of the target, which is the £23.5 million. but we do need to make sure that that identification turns into true delivery in order to ensure that we deliver the overall financial plan and recover the position from the month 2 variance. Now we do that through our finance and performance executive, and each of the divisions have given us, are working through those plans in terms of delivery. We're also monitoring delivery of this of our cost improvement programme through the relaunch Excel in Everything programme, which is led by Fiona as well. So I think there's good engagement by all the divisions. We've also done some deep dive line by line reviews, in particular with the emergency divisions, to come up with a remedial action plan, and we are developing an overarching remedial action plan for the organisation, which we will share with the ICB to give them assurance as well. But I think it's fair to say, we do need to consider the finances in the backdrop really of the increasing demand that the organisation is experiencing, which clearly wasn't set out in the financial plan because it wasn't expected we didn't expect this level of a continued increase. So I just wanted to make sure that board members are aware of that context as well.
Thank you, Kim. And I know you've been living through a nightmare with house fires and everything else, so really appreciate you joining us today in difficult circumstances. And we do know, I think it's fair to say, Kim, if the new financial reset leads to more of a PBR world, financially we'll be in a very good place. We just need to ensure that we don't cause a short-term embarrassment under the current financial regime as we finish the first quarter. Any questions or perspectives to Kim? I leave that challenge with you and Adam, Kim, and the rest of the team. Colleagues, happy to move on then to the capital programme quarterly update. So Sophie, we've had a lot of money, we're spending a lot of money. How's it all going?
Busy. So I think at the start of the year, we had a capital programme that was really manageable. We had really robust plans around delivering it. That was at 17.6 million. It is amazing that by the first quarter, we now have access to another 12, 13 million to really progress some of our ambitions. However, that does put quite a lot of challenge into the delivery within year. In terms of how we've moved that forward and the positives, so assured around the programme we set at the start of the year, if I start there. Really robust plans around delivering that programme that we set out in the 17.6 million. The other constitutional funding that we've got, there's some business cases on confidential board today. The equipment side of things, we should be able to progress, and we've got plans in place to do that. The risk comes around the funding for the emergency department. What we know is the estate is not appropriate for the demand that we've just talked about through board. We know it hasn't had that investment in a while, it's too small, etc. The positive is we now have a signed off plan from our clinical and operational teams about what we want to do. We are phasing that, and we do have confidence that we can do the first couple of phases. Part of that would be to put a CT scanner at the front door, which will really start to make a difference to the teams and their ability to manage some of that demand. And we'll bring that back through board. Adam's already said about the things that are the positives that are open in this. It was a really busy year last year, so we're starting to see some of that open, which is really great. But another busy and challenging year for the organisation and the board actually around that decision making.
No, thank you, Sophie, and thank you for your leadership in all of this area, Sophie. You've been spinning plates for longer than I can remember and making sure that none of them fall. Any questions or perspectives to Sophie on the capital update? Phil?
Sophie, your spinning plates is pretty dynamic. Do you have everything you need for us to absolutely get everything out of the funding that's available to us?
Great question. I do. Obviously our delivery vehicle is through SWFT Clinical Services, and I have had conversations around capacity within the company to deliver the programme now that it's almost doubled in size, and they have come back with some plans around some agile resource to enable us to ramp up and down. In terms of the ED scheme, we got ability to draw down 9% to enable us to continue to move forward whilst working on the business case. So that has been used to bring some of that additional resource in. So right now, yes, I think we've increased it to manage it. That being said, it is a big ask to deliver all 4 phases of that urgent care programme. So any mechanisms that we can pull towards the end of the year to carry over, etc., we will be using, and Kim is helping me with some of that conversation. You'll, Phil, be aware as the non-exec lead for sustainability, we've also potentially now going to have access to further funding for Salix. So again, that we would just need to reflect the resource if we're successful with that, because we would definitely need some more input on top of Chris's role to help make sure that's a success.
Thank you, Sophie. Thank you, Phil.
Just encourage you to, as we get more funding or as it gets more dynamic, to keep answering that question yourself.
Yeah.
No,
Yes.
well made, Phil. Thank you. And Robert?
Sophie, I was just looking at the phasing of capital, and you'll know more than any of us that it gets a bit lumpy, doesn't it? It doesn't tend to kind of travel in a nice kind of linear line. Are there any plans to kind of look at the quarterly phasing of the program, just so that if we're getting updates, we know whether to be concerned or not concerned about how things are going?
So we're doing that exact piece of work right now. So we're doing the forecasting. The finance teams are working alongside the leads to do the forecasting on all of those pieces of work. So that actually, I think what would be helpful for the board is just to say how much we plan to spend each quarter, because it won't be like that. And then you'll have that assurance, and I'll be able to flag then the risks to the board around where we're off our plan. So that detailed piece of work is happening now on that additional funding.
Okay, thank you.
And any other questions or perspectives to Sophie? Okay, Tim, we'll move on then. And one of the things we do is to try and get an annual assurance statement from our audit committee and clinical governance committees together. Robert and David, over to you on this, please.
Okay, it's a brief but reasonably comprehensive list of the areas that the committee uses to get its assurance and then provide assurance to the board. That principally comes from internal audit reports and opinions and external audit reports and opinions. A really important statement is the annual governance statement, which is signed by the accounting officer, the CEO. That features in the annual report, so that demonstrates to the public and uses that information where our systems are working and how we know whether they're working. And then finally, reports on counter fraud, information governance and security. So that's not everything that the committee does to provide assurance, but those are the main sources in the joint statement this year.
Thank you, Robert. David, just out of politeness, anything you'd like to add?
Nothing to add.
Any questions or perspectives from colleagues? Very assuring, thank you. And then we'll move on to the report for the audit committee of the 11th of June. Back with you again, Robert.
Yeah, really just the main points that I'd want to bring to the board's attention are there. I mean, the audit is ongoing. The teams are working very hard. We've provided our external auditors with some additional time to do some testing for the accounts. So there'll be further audit committee meeting and board meeting if everything is acceptable to approve the accounts. So that notwithstanding, there's been an extension that remains on track. But the committee had a very good and thorough review of the draft annual report, accounts, quality statement, and that's looking really good. And as chair, I'd like to extend my thanks to everyone that worked on that. It's no mean feat.
Thank you, Robert. Any questions or perspectives on that audit committee report from Robert and colleagues? So in a similar vein, then we'll move on to David and the Clinical Governance Committee report for the same day, apparently, David. David?
Yes. I've nothing additional I want to add, and to some extent, Fiona covered many of these things in her earlier report. So I'm open to questions.
Okay, thank you. Any questions or perspectives to David on that clinical governance report, which Fiona preempted? Okay, thank you, David, and thank you for everyone involved in that. So obviously one of the ways we as a board gain assurance and manage risk is through our risk committee, which is an executive-run risk committee run by Adam, and our board assurance framework and risk quarterly report. So, Adam, do you want to introduce these? They're very thorough, 68 pages.
Yes, thank you, Russell. So this is the first board assurance framework of the year. So within it, we have closed down last year's board assurance framework related to last year's strategic objectives, and you'll see that in the papers. But we've also set up the new board assurance framework related to the strategic objectives for this financial year. We've changed the format of the BAF this year based on feedback from our auditors and from colleagues, just to assure we've got a really clear view for each of our objectives of the current risk position. So a lot of work has gone into that. I think the format it still requires some tweaking, so I'm happy for feedback from board members on that, but it does reflect the current risk position with all of our strategic objectives in one place. The other thing we've included is the red risks on our risk register. And I think it's fair to say we are an outlier for the number of red risks we've got on our risk register. And I don't think that accurately reflects the risk position in the organisation. I think there is a heightened awareness of risks in relation to the financial situation, in relation to the increases in demand, and in relation to the CQC inspection we had in March, which has led to some risks being rated in a position where perhaps they are higher than we would expect. Between myself and Fiona Burton, Chief Nursing Officer, we've got a piece of work to really deep dive into our risk position. I think in terms of the way we rate risks, there is the potential for some ambiguity. So we have a piece of work to look at our risk scores and ensure that there is no ambiguity in those, and to provide training, particularly for our divisional triumvirates, to assure they've got the knowledge and skills to be able to do those risk ratings. We'll also be continuing a programme we've had in place to deep dive into all of our red risks. I'd also like the way we improve the reporting of them to board. So as Russell said, there's a lot of information here. And so we're going to look at a more concise format, ensuring all those risks are on there. And I hope next time this comes back here in a quarter, we'll have a clearer BAF summary, but a much clearer summary of red risks alongside that. We're also going to look at our Risk, Health and Safety Committee to ensure that the scrutiny that we're giving to these is appropriate, and that they've got the time to be discussed and fed back from our divisions. So still work in progress, but as it stands, this gives an accurate position of the BAF for our strategic objectives and an accurate position of the red risks currently on our register.
That's great, thank you, Adam. Questions and perspectives, Phil?
Yeah, good to hear, Adam. And as we assemble and tidy up that list, let's just put as much effort into the mitigations and tracking them and who owns them, because that's important. That's a really important bit of risk.
Yeah. Other questions or perspectives to Adam? Sophie?
Just looking at the community integrator and lead provider together, the ability for us to be a lead provider will be judged on our delivery of community integrators. So as we tidy it up, I think we bring that back to board in either October or September, I can't remember where it's scheduled. I think having a conversation about those risks together would be helpful because they're so interlinked. So if one's red and the other's amber, we've got to ask ourselves, if we're red on that can't be amber. So I think I'd welcome us having a risk conversation about lead provider when we bring that back as a workshop discussion.
No, point well made, thank you. And Adam, do you think we are correctly assessing the EPR risk, the new EPR system risk in this work?
If you were to ask me today what one of the areas I'm really concerned about in terms of our strategic objectives, I would say that the EPR is right up there. So I do think that deserves a bit more scrutiny.
Okay, Fiona, were you on the same point, or can I continue?
No, you carry on. No, it's different.
because I think we did have a session. I know we've got another session with our friends from Innovate, and you and I have had sessions with SSC, the contracted supplier with Oracle of the system. I do think this is something we need to talk about more often at the board, Adam, over the next year as we progress the work, because we're in that critical period now, as I know you well appreciate, but just for members of the public, that the decisions we make now will start to get set into concrete and will have significant consequences on the way the acute works going forwards. And finally, Fiona, then we'll move on.
Yeah, just picking up on the risk register, Adam, and the first two risks are related to some of the findings of CQC, and I just wanted to assure the board and the public and our regulators that these are two examples of what Adam was just saying. So that rating of 25 for a lack of a consultant PEM, a PEM consultant, a paediatric consultant in A&E, sufficient trained paediatric nurses. We've responded to CQC to say some of their narrative on that is inaccurate, and therefore, and we do as an executive team believe that these are not 25 rated risks, and that ED is safe from a staffing point of view, and particularly paediatric staffing. So I thought it was very important to pull that out in light of our regulatory enforcement at the moment.
Okay, thank you very much, Fiona. Any other questions or perspectives? Okay, we'll move on then to the summary of ratified policies. Adam, anything you'd like to add to this paper?
No, I will take it as read. Russell, 2 policies ratified.
Okay, thank you. Any questions or perspectives from colleagues? Okay, so we're then on to the summary of health and safety annual report. Jack, what would you get to pull out?
Thanks, Russell. Just a few key messages. Firstly, compliance with departmental audits is extremely high, ensuring that the risk of non-compliance with health and safety legislation is low. We reported 22 staff and 3 patient incidents to the Health and Safety Executive under the reporting of injuries, diseases and dangerous occurrences regulations during 24-25. Violence, abuse and harassment incidents remain in the top 5 reported incident categories across the divisions. But as part of our response to that and our part of an improvement in that area, the Trust have invested in lone worker devices that have been rolled out across a number of teams and divisions in the recent months. Other than that, no other key points to pull out. Happy to take any questions.
Okay, great. Thank you. Any questions or perspectives to Jack on health and safety? Oliver? Ollie, sorry.
No worries. Yeah, given we have a red rating on the BAF for staff sickness, and I know we're trying to, there's some good work going in the right direction. It was mentioned earlier around mental health. Really, it's musculoskeletal is the second highest reason we've got absent. Are we assured that via the HSE we're doing enough around musculoskeletal health of our staff?
I'll have to take, unless Alva can come in on that, I'd need to take that.
Yeah,
Alva?
Yeah. So we are very aware that that is our second highest reason for absence, and what we're doing in terms of looking at what staff groups those are, delving a bit more into the detail as to where they work and what they have in terms of support on the wards, particularly if the job is to work with individuals where they are having violence from patients or having to restrain, which then can cause musculoskeletal. So there is some triangulation that is happening with regards to that, but also picking up for our staff around early intervention through our self-referral, staff referral for physio, which we have within the trust. So looking at reactively giving that to staff that are off sick, but also proactively looking at our wellbeing lead, infiltrating that within the divisions to remind staff and managers that we have that staff referral route for physio.
Okay, thank you. Alva goes back to the earlier discussion as well. Fiona?
I'm not sure if Adam or anybody else wanted to come up on that theme. I was going to change the subject.
Okay, so Adam?
Yeah, I think it's a very fair question, Ollie. And as Alva says, we do have schemes like the physio scheme, self-referral scheme, which help. But I do think this is one area where we see the impact of the challenges with the Occy Health service that we referred to earlier. So I would hope it's an outcome of the options appraisal that Alva has spoken about, a real focus on musculoskeletal and support options there is something a refreshed occupational health service will bring us.
Super, thank you. Fiona?
Yes, I would just wanted to add to Jack's report, in the absence of Harkamal, who I'm sure would have mentioned it, for transparency to the board and to the public. I just wanted to make note of a health and safety executive inspection that we had in May this year that's not cited in this report. They came in on the back of a staff incident, which was a Sharps incident. Although that happened about a year ago, it has taken them that long to come in and just double check our processes on safe Sharps. Generally a positive inspection with lots of good practice, and particularly the incident they believe was managed appropriately. However, they did raise a concern with us, which they've asked for us to formally respond to, which we have, and that was around the use and procurement and oversight of unsafe Sharps. Now, for the public's point of view, there's a number of suppliers that provide Sharps, such as needles and scalpels, etc., that have a safety device, so you don't have to put the top on it or the, literally yourself, you just click it over. There are others, like needles in theatre, that you can't have a safety device attached to it because it's too fiddly in terms of the work. Sorry, that's the technical term. So organisations are supposed to have a unsafe Sharps reduction strategy, which we were not able to demonstrate. So we have since set up a safe Sharp governance process, meeting, committee. We're drafting a strategy. We've done some risk assessments. We've taken the unsafe Sharps out of circulation that were there if we had a safe alternative option. So I'm sure Harkamal is intending to put that into this report next time, but just wanted to give you that assurance and transparency.
Thank you, Fiona. It sounds like a bit of a tongue twister, unsafe Sharps.
Yeah.
Any other questions or perspectives? Otherwise, we'll move on. Okay, thank you, team. And that segues nicely into the Summary of Security Standards annual report. Jack, anything you particularly like to pull out?
Thanks. Yeah, a few things here again. I get firstly, obviously, acts of violence, abuse, and threatening behaviour towards staff are completely unacceptable. So we'll always be doing everything we can to make sure that that's not occurring at our organisation. This report just briefly outlines that there's been some changes to the NHS violence prevention and reduction standard from the 2021 version, and the standard now encourages some prevention first strategies rather than reactive, and emphasises staff training, early intervention. As a result, we've done a robust gap analysis on the elements of that new standard, and we're currently working that through. The report references three red risks, three critical areas that the gap analysis has flagged up. One being that the violence prevention and reduction strategy has been discussed and formally approved at a public board meeting. That strategy is currently in draft format, will be sent out for consultation, and then will come back to this forum. The second risk is around the violence prevention and reduction strategy forms part of an overall organisational strategy, which it will do through that process. And Harkamal and Ellie Ward are working on that and linking it in with other ICS guidance in this field. And then the final risk identified through that gap analysis was on the back of her training needs analysis, a gap in face-to-face conflict de-escalation training. So Jackie Farrington, Charles Chambera and Fiona Dwyer are looking at some of the gaps we have in our training there and what options we've got to close those gaps to provide the relevant training for staff to help them deal with those situations as they arise. But like I said, there's a more robust gap analysis that's been undertaken, which will form part of a bigger action plan on this area. Happy to take any questions.
Thank you, Jack. Any questions to Jack on the Security Standards Annual Report? Just again, to re-emphasise the point I made earlier, I was incredibly impressed by the de-escalation techniques that the security staff were trained in. They are very professional individuals, and my thanks go out to them. But I would make the point to members of the public, you have no right to be aggressive, verbally or physically, to any member of staff who's trying to help you. You may be in a stressful situation because a loved one is in distress themselves, or you've been waiting a long time. But it is never, under any circumstances, acceptable for you to be physically or verbally abusive to a member of NHS staff. And we employ a number of security staff. For every security staff we have to employ, that's one less nurse we can afford to employ. So when members of the public on occasion think, why can't we have more nurses? But you're being aggressive to a member of staff, just look in the mirror and reflect on the need for self-control, even during periods of stress. So every security staff we have to employ, and I think we have a rota of about 3 or 4, quite often working during the day. That's 3 or 4 less nurses we can have on the wards looking after members of the public. Thank you again, Jack, and all of the team that are involved in that. Shall we move on then to some of the board committee minutes? So I think first up is the audit committee from the 9th of April. Just to remind members of the public, so once we've had a recent subcommittee, we have the report, which you heard earlier, from June. And then with a month delay, we have the actual full minutes for our records and for our assurance. So of the 9th of April audit committee minutes, anything you'd like to pull out, Robert?
Nothing to pull out, Chair.
Any questions from colleagues on the audit committee from the 9th of April? Okay, thank you. And then similarly, the 14th of May clinical governance minutes. David, anything you'd like to pull out?
No, nothing from me.
Okay, thank you, David. Any questions from colleagues? So I think we've gone on to, got a very full confidential board, colleagues, which I'm aware of, but any other business from board colleagues? Can't see a digital hand raised. Have we had any questions from members of the public, Sarah?
Mike Well submitted 2, which Adam has addressed the first one under the BAF item around the number of red risks. And then he's also submitted a question for David Spraggett on the Clinical Governance Committee minutes of the 14th of May that notes that a palliative care report is being developed after a review was completed. Mike asks whether the review included Shakespeare and Myton hospices and Shipston Home Nursing, all of whom work in partnership with the Trust.
Fiona, in terms of, we mentioned the palliative care review coming back to us, but in terms of Mike's question about the hospices relationship with that review, will that be incorporated?
I think there should be mention of the relationships and the partnership working as part of our model of care across Coventry and Warwickshire, but the review was specific in terms of it was an internal review of our provision, but obviously that has to link with our partners because our patients are cared for by those organisations mentioned. So there'll be reference to it, but it was more specifically about what resource we have, what are our standards of care, etc. The partners were informed of it and have been given the feedback from it, but it was specific to Swift Care.
I think it is a good challenge from Mike, though. And Fiona, maybe if you and I can have a chat before the next board,
Yeah.
Because we know there is spare capacity, but it's unfunded spare capacity, and quite often it's expensive spare capacity in the hospice sector. But it might be good to make sure that just in terms of our frail end of life pathway, the way we as a system need to work, and it needs to be, I think, considered. So if you and I can have a chat and then we can take that forward, that'd be super.
Yeah.
And we've got a few minutes, so members of the public, great to see so many of you with us today. If you'd like to ask a question now, do you want to raise a digital hand or come off your mute? Elizabeth, lovely to see you at today's meeting.
Hello, I have sent an email actually to Sarah and to Dawn asking if I could have a bit more information about the award from the wheelchair services, please. It's probably not for saying now. I did a report on it before COVID when there were loads of criticism. So I'm just interested to know what's happening about it now, please, if that's possible.
Of course, Elizabeth. I'm not sure we received the email, so we need to look into that. But Fiona, did you know where we are on this issue?
I've only done it today. Sorry, Russell.
Oh, Elizabeth.
Well,
I thought you'd sent it in weeks ago.
No, sorry, I'm busy.
We'll get you a proper reply. But Fiona, do you know where we are at the moment?
Yeah, I think if I heard you rightly, Elizabeth, it was about the award that we referenced earlier, or Adam referenced. So that award was a HSJ award regarding a chat box that the wheelchair services have put in, which is a digital platform where patients can raise questions to the clinical team related to their referral, or to get more information about when they're going to be seen, or how they can ask for help. But outside of here, Elizabeth, I'm sure the wheelchair services can give you a broader update about how managing services now.
Elizabeth, it's been about a year since you, Fiona, and I have had a coffee and a little march around the trust. If your diary allows, can we try and put that together over the next couple of months?
Will do. Yeah, I've recently. Sorry. Thank you, Fiona, for that. I'm just interested because, sorry, Russell, I'll answer that bit because although I am a user, I've only had a cushion off you and seating mapping. I don't have my wheelchairs. The police pay for my stuff, thankfully. But yes, so thanks, Fiona. I'm just interested in it because. But Russell, yes, please. And recently I have done a walk round of Ellen Badger and the CTC, and I'm coming to look at the elective hub next week with Liz Waters. But yes, I'd like a walk round again, please.
Okay, well, if outside of this, if we can see if I can join you when you're in next week rather than get you in again, and we'll try and have a coffee then. And if Fiona's around,
thanks, everybody. Thank you.
The two of you. Any other questions to the board from members of the public? Okay, well, lovely to see you all. The next board meeting is a 4-board foundation group meeting, which I would really encourage members of the public to come along. They're a different type of meeting and are valuable in a different way. So look forward to hopefully seeing you then. Otherwise, our next board at SWFT is at the beginning of September. Look forward to seeing you soon. Board colleagues, can I suggest we get going again at 3 p.m. to try and save you some time this afternoon. So see you soon. Thank you.